John Guynan with Interventional Radiology. Going to talk through a case of hydronephrosis and percutaneous nephrostomy tube placement. So we have a patient who was admitted, was found to have, I think flank pain was the initial admitting reason, found to have this, soft tissue thickening in the base of the bladder concerning for malignancy, and also, right at the area of ureteral implantation on the bladder, and then there was resultant bilateral hydronephrosis. So the kidney's function was starting to decrease, as noted by increased creatinine levels. Urology had seen them and was usually they try to place ureteral stents first, but because of the soft tissue mass, they couldn't clearly see the orifices. So he still needs decompression. So they wanted us to do bilateral nephrostomy tube placement, which we were happy to help him out with. So when we place nephrostomy tubes, we do it under ultrasound and fluoroscopic guidance, and the best place to get access into the urinary collecting system in a percutaneous transrenal approach is along this mythical line called the line of Brodel. And the reason that is what we aim for is because it's theoretically the least vascular plane in the kidney. So when the renal artery comes in, it breaks it off into anterior and posterior divisions, and those two divisions kind of have their smallest capillaries right at this kind of, 5 o'clock position when you're looking at an axial image. So when we get access, we're trying to, somewhere along these lines. Now, there's not like a real imaging landmark that we can use to aim for that, but typically kind of in this orientation is what we're going for. Let's see if I can find it. So again, unfortunately, our ultrasound images are not coming across very well, so we'll just look at the fluoroscopic images, and we use the ultrasound to get image into the kidney. So in this case, it was bilateral, so I put a needle in through the skin and into the urinary collecting system under ultrasound guidance. Typically, we're going for the inferior or middle pole. I like middle pole better if the urologist and I want to get access all the way down into the bladder. If we know we just want our catheter to stay within the kidney, inferior access is fine. Sometimes people want superior pole access if there's specifically a stone or something they want to have access across. That can be a little bit trickier just because we're closer to the ribs and the pleural space and potentially bringing the spleen and liver into play. So typically if we just want access somewhere, middle or an inferior calyceal access will work. So we get access with a small gauge needle. It's a 21 gauge Chiba needle, and so if we have to attempt it a couple times, that's less risky than going in with a bigger needle like an 18 gauge. And once we get access into the collecting system, we put a small caliber wire, a micro wire, into the collecting system, and then we have a special catheter called an AccuStick catheter that we can put in over the small micro wire, and there's an inner and an outer component to it. And once we get access with that catheter into the urinary collecting system, we can take that inner wire with the inner catheter out, and what's left is basically a 5 French catheter that we can put a typical non-micro wire in, and then once we have that access, we can put our tube in over it. So the whole thought process with that, it's not important for you to know the sizes, but we use a small access needle which we then dilate up so we can get a bigger, sturdier wire to push our tube in over. So it kind of is a combination of making things as safe as possible and also eventually being able to get enough support to push a tube in through the skin and the renal cortex and get it positioned where it needs to be positioned, which ultimately we did. And then here's our other side images. And here's our final images. So a pigtail catheter into the urinary collecting system through the inferior calyx on both sides. Now the urine will divert out to the draining bags instead of going down to the bladder, which is obstructed by tumor. So eventually, once he gets the bladder tumor taken care of, we can cap these catheters and have him drain internally. If he doesn't have any recurrent symptoms of flank pain and the labs stay good, then they know they can take the nephrostomy tubes out at that time.